everyone, Lisa Home here. Hope you're all having a great day. Today's lecture, we're going to continue with interprofessional teamwork and collaboration in Lesson 3, and we're going to explore data today. The objectives of the lecture are the same. I'm going to just skip right through them. I read them to you in the first Lesson 3 lecture. We're going to talk specifically about the role of the nurse in QI. This follows a little more of our chapters in the textbook than what I was discussing with you about teamwork. The definition for quality improvement in nursing is to use data to monitor the outcomes of care processes and use improvement methods to design and test changes continuously and to overall improve the quality and safety in healthcare. And the purpose of this is going to drive this home, and it is well represented by your assignment in the course. We're going to talk a little bit about PDSA. This really is going to bring us into the project that is selected for you this subterm. The responsibility of the nurse in QI is to decrease inconsistent patient outcomes, to make sure that we decrease poor patient outcomes, so we don't want them to occur at all. We want to decrease patient outcomes that do not meet expectations related to evidence-based practice. So what we see in the literature, we hope to have the same results of what has been practiced in other institutions with other nursing teams. And we also want to align with regulatory standards. We want to minimize or eliminate processes or policies that do not meet the patient's needs or expectations. And then we want to use feedback and dissemination of those results. So whatever QI project you're working on, you want to make sure that you share those results with other colleagues, other institutions. That's how you get into publishing and other things of that nature. The IOM initiatives for nurses is that nurses' practice must be based on sound evidence. So our textbook talks a lot about discriminating or differentiating between quality improvement and evidence-based practice, but we're just going to go over the aims of each one to make sure you understand the differences. So QI is the analysis of data. The whole purpose of that is to inform your decision making and to determine if improvement is warranted. So based on what you pulled, your baseline data is going to show if you need to make changes or if you do not. Then let's talk about the aim of evidence-based practice. So evidence-based practice does not analyze information. It doesn't use data or it doesn't seek to problem solve. Rather, it critically appraises. That means we scrutinize in the way we evaluate all relevant evidence. That means across the board. So all literature, all research that has been done on one topic, for example, to answer a clinical question, an educational problem or issue, or an administrative question. And the other aim of evidence-based practice is to determine if evidence supports clinical, educational, or administrative practice in general. And if it doesn't, then do we need to create new evidence that can support our practices? The IOM has called for a stronger body of evidence-based practice, and sort of the backstory of this, and this is following the aim, so I will go over the aim of research, another body. But QI began its work with the American Medical Association in the early 1900s. Over time, it changed to standardizing care into measurements and the process of care in evaluating healthcare outcomes in response to accreditation standards for the Joint Commission. The current focus continues to evolve in response to CMS initiatives such as value-based purchasing, and we did talk about that in another lecture. The IOM essentially called all healthcare disciplines to create a greater empirical evidence-based care delivery by each specific discipline. Through the KSA, or the knowledge, skills, and attitudes of QSIN competencies, remember there are 6 of them that we went over in our previous lesson, nurses are better prepared to question practice, to evaluate the literature, and take an active role in the QI process. Now back to research. So every discipline is responsible for creating its own body of new knowledge. Finally, nursing does that. And historically, we stole all of our knowledge from other disciplines and a lot from psychology. So the aim of nursing research is to generate new knowledge by testing theories and/or interventions. And these are the most popular research foci on your screen, which is health innovation, population health, precision health, and data science. Those are the 4 main areas of where research is right now. And then your textbook talked briefly about the Donabedian model for QI. And there are 3 parts of it that comprise it. It's structure, process, and outcomes. Structure is the condition under which care is provided. That makes sense, right? And under structure, there's infrastructure, demographics, technology, education, and facilities. Under process, the activities that constitute healthcare, such as policies and the standard of care. And under process, that would constitute diagnosis, treatment, appropriateness, process of care, and resources. And then outcomes is the 3rd domain, and it is changes in individuals and populations that can be attributed to healthcare. And under that domain is mortality, morbidity, cost, factors creating cost, and quality of life. So the proposed model is of quality assurance. It's been used the past 50 years in healthcare. It's our guiding framework for patient safety and med errors, and the focus should be on promoting exemplary patient and family and outcomes. And also wanted to mention that the aim is to identify nurse-sensitive measures that could demonstrate the impact of nursing care on patient outcomes. And again, these 3 processes that you see on the screen. There are some great models that we utilize to underpin, they act as our framework for quality improvement. And the most popular one, the one we're going to be using throughout this course, is Edward Deming's model to implement QI projects, the PDSA model, or Plan, Do, Study, Act. Some people call it the PDCA, Plan, Do, Check, Act. And we're going to be going into lots of details about those, but I'm just going to mention that's one of the most popular models used in healthcare. And then the Sigma 6 and DMAIC is another. It's a more advanced methodology. It started or it originated from the business sector. It's 6 Sigma. It provides 5 steps for QI to reduce variation in performance. Define, measure, analyze, improve, and control. That's what DMAIC stands for. They are called lean interventions, and they focus on improving efficacy, reducing waste, and streamlining processes through cumulative effect of small improvements. Healthcare failure mode effect analyses. If you look on, it's assignment 3, if you look on the guideline, it mentions that as an example. But to explain, it's just a QI tool that looks at a healthcare process to determine the potential for risk. If you decide to keep going on for your master's, you will be diving into these principles and these models much more deeply than we're doing here. We're just touching on them. And I wanted to just show you an example of a dashboard. Examples of data. So your chapter 14, which we're going to get to in just a second, goes through all these different statistical measures. They are really displays for data. And you may think, I don't care, what do we need it for? So we're going to mention some of them in your project, in your quality improvement project that you'll be working on. But I just want to start to expose you to these concepts, because if you continue to move on and you go through your master's, we're really going to kill you with some of those statistics. So it's better that you familiarize yourself. But what I'm so impressed about is if you do any quality improvement measures where you work, this is a common dashboard. If your interventions are making any improvements, or where you will initially record your baseline data. So I just wanted to give you some idea what the heck that was. Chapter 14, we're going to do a quick review of data. So the process for quality improvement for utilizing the tools, and you can follow them around. The first is just ensuring that the culture establishes quality in every practice. Remember, it's all about that commitment. Those are some of the qualities of an HRO organization. The second is determining and prioritizing areas of where we need to improve. The way to do that is patient safety is first. So which one has the likelihood to cause the most harm, and you work and prioritize those first. The third is you want to work on data collection and analysis. And then 4 is to communicate with your colleagues about the results, right? We have to disseminate that, and then you can get their feedback based on the results. And then the 5th is a commitment to a continuous evaluation. So as we implement changes, is it continuing, or are the staff sliding back into their old habits and they're using workarounds again, things like that. And the 6th is to expand your successes. In assignment 3, we ask you to create a data collection plan. And so I wanted to just introduce some of these terms to you so they're somewhat familiar. So one that we mention is an internal source for data, and that's collected by staff, like within the organization. So that's if, let's say, you count how many falls occurred in your organization over a month, or how many med errors occurred. That's internal data. External data, which you see on the right side, is collected from an outside source. It's evaluate on a report of the organization's internal processes and outcomes. And they call these in general types of secondary data. So what's nice about this little figure is that it kind of shows how everything relates. And then baseline measure is just what is the state of where you are. This is really what confirms your hypothesis. If you think, you know what, patients are slipping and falling because of X, Y, or Z, let's test it. So this is when you do your baseline assessment, and really it confirms or verifies that the problem is in existence. Post-intervention data, and I'm giving you just an example of pre-test, post-test. That's more of a research study, but in quality improvement, it's pre-intervention and post-intervention. There are changes from the baseline data after the improvement intervention, and it confirms either successes or failures of that intervention. And again, like an example, the team is working to decrease, let's say, hospital-acquired pneumonia over the past 3 months, and what does the data show? The next is the bathtub analogy. And this you're going to use in population health. So we'll talk about this. This is a model of epidemiology, but your textbook mentions it, so I'm just going to go over really quick. An incidence is just a new case of disease occurring over a specified period of time in a population. And prevalence are the number of cases or disease that are at a specified time in population. And then data aggregation. So in QI, projects generally use aggregate data. They will use large group data without patient identifiers. And then examples of that would be staff's adherence to hand washing practices, things like that. And notice the data shown here, what a pre-intervention and a post-intervention could look like. You'll find that in quality improvement, it's not just enough to verbally tell your information. What's really nice is the way that you display your data help improve understanding amongst your colleagues. And this just shows the overall QI process. We're going to go through specific data displays that are recommended in your text about quality improvement projects. And the first is a histogram. And you'll find that with displaying data, there's a specific reason, or you should use a certain data display depending on what you want to do with it. So you want to use a histogram when you have continuous measurements and you want to understand the distribution of values and look for outliers. A Pareto chart is for defect analysis. So it's usually a graph that indicates the frequency of defects as well as their cumulative effect. This is scatter plot or a scatter chart. Works best when comparing large numbers of data without regard to time. It's a very powerful type of chart, and it's good to use when you're trying to show a relationship between two variables. Like for example, looking at this, there's an X and Y axis. So you could say a person's height and weight, or their age and their height. Next is a control chart versus a run chart. So a run chart is used to study observed data for trends or patterns over a specified period of time, and it focuses attention on vital changes in the process. It's useful for tracking information and predicting trends or patterns. A control chart, on the other side, is a graphical tool used to determine process performance with time. It's also called a Shewhart chart. It's helpful to use a flowchart diagram to organize a sequence of events. Nurses see these often with protocols or nurse-driven protocols. Then I also wanted to share what this is. This is the greatest thing I have ever learned in QI, which is a parking lot. Have you ever been in a meeting where the meeting goes off on a tangent, somebody sidebars the meeting? The amazing thing that happens in the sidebar is that these brilliant ideas are happening. However, it's unrelated to the meeting you're actually in, so that part's not good. But what's great about it is I always bring like a blank piece of paper or something with me, because you never know what other great ideas will come out of the meeting, related or unrelated, and that's called a parking lot. So you can organize they show a chart, which is really cool, but a lot of times what you do is just bring almost like a big empty poster board and you just start sharing of ideas. If you go off on a tangent, really generate great ideas. And then a Gantt chart is a helpful chart for planning and scheduling projects. It gives you your timeline. It shows where you are in the phase of the project, so that's really helpful. And that's all I have. I hope you have a great rest of your day. Thanks for listening.